Good day and welcome to Just the Balance. Thank you so much for joining us. My name is James Seetelo. And today we are joined by Professor Nicholas Crisp. He's the Deputy Director General for the National Health Insurance right here in South Africa. He has been a health systems advisor across the African continent. He's also a medical doctor by profession. Doc, thank you so much, Prof, for joining us today. Now, you have spoken widely about the national health insurance. However, today, I want us to really move past the politics, including also the legal battles that we have seen unfolding before our eyes. Let's speak about now, as South Africa is getting ready for the implementation of the national health insurance. I'm also reminded that we are not the first country in the African continent to introduce the national health insurance. I've seen countries like Ghana launching their own. They also had challenges of their own about 15 years ago, including also out in Rwanda. Now, looking at the mistakes they may have committed, including also other challenges they committed along the way or they experienced along the way, what do you think we can actually take away from them, not to commit the very same mistakes, but just to learn from them?
Yeah, hello, James, and thanks very much for the interview. So I think the starting point is for us to recognize that there's no country who has a completely happy working system where everything performs beautifully. Mm-hmm. All countries are grappling with how to get more efficient, better coverage, and so on. And across the world, we are all striving for universal health coverage. Mm-hmm. So we've been looking at what other countries have done and are doing. And we are one of the last countries in the world that is not implementing universal health coverage and a universal financing system. So we have many examples to learn from. Every country has a different starting point and every country has a different makeup. We are essentially a federal country, so the nature of what we are trying to do will be different from a unitary country or someone who's got a kingdom or another structure of government. But there are many lessons, and the basic lesson across the world is to go for a publicly funded single-payer system, and that's how ours is designed. Even within single-payer, publicly funded systems, there are different ways to build the structure and to manage the way that system is financed. The most recent, the one we've been quite intrigued with, is that China started implementing a system that did not work for them, and they have switched to a single-payer system very quickly, mind you. We've been watching what's going on in Thailand, we've been watching what's going on in Indonesia, Malaysia, and other countries in the East. We know that Rwanda is implemented. I was personally involved in Ghana and in Nigeria's national health insurance. So there are many lessons from across the world, and we will have to tailor-make to our own environment.
Absolutely, Prof. And now let's bring it back to South Africa. I mean, you are a public health specialist, so you know the challenges that ordinary South Africans have been facing here. I want us to speak about that, considering that we have so many South Africans who wait hours and hours waiting for services at local clinics, including also hospitals. How will the NHI ensure that an ordinary person watching this interview now will be able to access healthcare without any hassles?
Yeah, so the challenge that we have in this country is that more than half of the spending that we incur in health as a population is spent on a very small portion of the population in a private healthcare system. It's both privately financed and it's privately delivered. And then there's the more than 50% less than 50% of the money is spent on somewhere around 85% of the population. The public system is responsible for all the big primary healthcare interventions like immunization, HIV programs, malaria program, TB program, etc., etc. And that is not paid for at all in the private sector. So the resources are concentrated in the private sector. What the NHI does is it says, let's pool all the money, the current 100 plus different streams of financing. Let's pool that money. Let's have one common set of benefits that we all know this is what the fund is paying for. Outside of this set of benefits, the fund is not going to pay. And then the fund is required by the National Health Insurance Act to purchase from both public and private providers. So what that means is the fund must purchase the healthcare of the security guard and the domestics in a suburban complex from the local GPs and the local clinics, that they do not have to go far away for care. It means that the fund will purchase care for people who currently cannot afford from a private hospital They may be living right next door to that private hospital. The fund will now pay for that care so that they don't have to trek 40 or 50 kilometers to a public hospital. So over a period of time, as the fund is paying for our care, it will be the nearest facility that is able to offer the care that we need at that point in time.
Yeah. Prof, would you say that is part of fixing the foundation? I mean, I'm not a builder myself, but I know that a good builder will say you need to start with the foundation.
Yeah.
So what you have just spoken about, I'm listening to you, then I'm thinking that this is actually part of the foundation to make sure that before we get to implement what we are implementing, we start from the bottom.
Yes, sure. So what we need is to be able to administer all of this money. So you need the structures to be able to do that. You need the digital systems to be able to monitor our digital records when we move between different providers within the system. We need to be able to report and account on the money. We need to be able to pay the providers. All those things that are required, those are the foundations that we're busy with now. But service delivery is still going to be provided by public and private providers.
So as I mentioned, as a just balance, we speak to an ordinary South African, someone who's going to this local clinic, going to this local hospital. I've got a scenario here, Prof, and I want you to help me with this. We have a single mother who's probably earning about 7,000 a month, and now she's just wondering, with the implementation of the national health insurance, does it mean that she's going to be taxed more? She can't afford it already. Does it mean that we are going to tax her more? What are we going to do? What is going to be used as a funding model, so to say, for the national health insurance, beside actually taxing the poorest of the poor more?
Okay, so at the moment, the total spend in public and private sector is getting close to 600 billion rand a year.
Yeah, that's a lot.
But under 300 billion a year, somewhere around 295 billion this year, will be spent in the public sector. All of that money comes from existing taxes. The problem is the way the money flows. So the bulk of that money is paid to the provincial governments as a lump sum. And each provincial government then allocates money to healthcare, and they run the health services themselves. There's also money that is, we call it appropriated by the national parliament, and that money is given to the national department to pay for some national interventions. So the national department does not deliver any health services at all. What it does is it gives that money to the provinces on top of their provincial share, and that's how it works in the public sector. The problem is the other half of the money, 51% in our current estimation, that is spent in the private sector. And that money it's voluntary, but it's out-of-pocket payment. It's what we call pre-financing or voluntary health insurance through medical schemes, and it is also insurance products and other kinds of products that people are spending. And the question is, how do we, the big challenge is, of course, that government subsidizes the private sector hugely. And the way that is done is by not collecting a portion of the taxes to people to encourage them to have medical schemes. That's worth about 34 billion rand a year. And then the state subsidizes its own employees to the tune of close to 70 billion rand a year to belong to medical schemes. Now, the administration of those medical schemes is expensive because there's so many. There's 71 medical schemes administering over 300 different packages or options, and it's very confusing to the public to know what am I actually covered for. So the point is that we should shift that money together with the existing taxes. Now, it can't be done by waving a wand or just suddenly moving it. There are processes by which we need to shift the way that the taxes are collected and collect it for the collective pool to be paid for by the fund. The mechanisms must all be in place. I'm not suggesting, as the media seems to sometimes suggest, that on a Monday morning somewhere the minister will wake up and just announce that all your money is going to be moved. So for the lady with the 7,000 rand a month, she shouldn't be paying any additional taxes anyway now. She is paying VAT on what she buys, and she may or may not be traveling in a taxi, so she'll be paying fuel levies, etc., etc. So she's paying tax. She will pay nothing more. But for the person who is wealthy and who's on a medical scheme and has a good job, at the moment they are getting a subsidy. We need to collect that subsidy and put it in the fund so that you no longer need to have a separate financing mechanism, and even those wealthy people can just go to a healthcare provider and the fund will pay for their healthcare.
Yeah. Now, one of the things that you mentioned earlier on was the media reports. Now, some of the media reports that we'll have seen, whether on social media or traditional media platforms, was that there's not going to be a need rather for your medical aids going forward. And I wonder, is that maybe what the National Health Insurance is trying to do to replace the medical aid, the private medical aids?
Yeah, so the problem with the current system is having 71 medical aids with 311 different options at the moment. They are reducing, and there used to be 200, so it's getting fewer. The way medical aids work is by creating what's called a risk pool. So the number of people and the conditions that those people are likely to suffer from makes it possible for the scheme to share that money and to pay out for those people who get sick when they get sick.
Yeah.
But it selects people who are naturally healthy, and it ignores the people who need the most health care, like women who get pregnant, small children, and so forth. And by making 71 different, in fact, it's 311 different risk pools. It's not even 71. Even with what they call risk equalization mechanisms, where you subsidize one package by another package, the pool is just not big enough to get efficiencies. And then every one of these 71 medical schemes has got to have an administration. Some of them are too small, so they buy an administration from a company who charges them to run that administration. All of this adds expenses. So nobody is saying we don't need medical schemes. We're saying we don't need 71 medical schemes. We don't need 311 different options. We need one big option that everybody knows I'm covered. That's what the National Health Insurance is about. Anything that at any point in time the fund is not covering, it's the right of the individual to go and insure themselves one way or another to have that covered.
Absolutely. Thank you so much. And we are in conversation with Professor Nicholas Crisp, the Deputy Director General for the National Health Insurance. And these conversations really matter to you. That is why I am encouraging you to like this, including also share it with others. It is Timia Africa on YouTube. Make sure that you subscribe and share it with others.